Would you lead us?
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Be here today, so Commissioner Harper. Present. Commissioner Reeby.
Here.
Commissioner Brooks should be here in a minute. Commissioner Willie.
Here.
I'm here, and Commissioner Purdy said she will be a little bit late. So, I'll go to the agenda. Is there any changes to the agenda? It can all be information or guidance. During that, I need a motion, we approve the agenda.
Is that
Ask for a motion for approval.
I move we approve the agenda as presented.
Second. Move second to approve the agenda as presented. All those in favor?
Aye.
Aye. Motion carries. So at this time, is there any person or public comment, excuse me, legal comment?
There's no in person and no one submitted electronic.
Okay,
Thank you.
thank you. Okay, introduction of new employees.
Hello. Hello.
So I would like to introduce Norma. She is our most recent clinical assistant in WICS.
My name is Norma Centeno. I've been working with WIC for a little over 2 months as a clinical assistant.
Oh, awesome. Thank you.
Thank you. Thank you for your time.
Norma.
Thank you.
Didn't cheer off.
I know, right? I had to grease the wheels.
Oh, good one. Great one. Okay, has everyone had a chance to read the minutes? I'd ask for a motion to approve. For any changes.
I move we approve the minutes as presented.
It's been moved and seconded to approve the minutes as presented. Any discussion? Hearing none, all those in favor? Aye. Commissioner Brooks is now entered the room. Thank you, Commissioner. Certainly. And Lashers. This time, we will go on to the May 26 expenditure and revenue report. Michelle.
Yes, thank you, Chairman. Thank you. So this report is as of May, the end of May. Everything's been processed through our Luma accounting system. And we are 91.67% through the fiscal year as of the end of May. We've got about a week and a half left of our fiscal year, so the group's getting everything into the system before the year ends. So at the top left, you'll see the ending cash balance at the end of May, the $1,289,688. And over to the top right there is the summary information of our year-to-date revenue and expenditures and our month-to-date. And our year-to-date expenditures are just slightly over our year-to-date revenue there. Down this first page is all the programs and the revenue collected during the month. Excuse me, and the year-to-date totals. And overall, we are at 84.11% of our budget. And that's about 7.5% below the target of 91.67. And this difference is due to a couple of things. the committed and restricted funds are in the budget numbers, but they're not listed on the page. In the new year, I'll make sure that those get in the report. So the revenues collected don't reflect those numbers because they were prior year revenues. So that's why you'll see some of the percentages on the right-hand side there are quite a bit lower than what our target is. The other issue that I identified was that we had a few programs where the budgeted revenue was more than what our sub-grant revenue that we lastly, there's a few programs where we've had some salary savings and so haven't had the personnel costs to bill health and welfare. For instance, like you'll see the public health preparedness program and the women's health check. We've had some savings there. Are there any questions on the revenue before we move on to expenditures? Okay, on page 2 are our expenditures by program, and our year-to-date percentage of the expenditures to budget is 85.11%. So that's 1% higher than the revenues, so pretty close there. And the variance between those is mostly due to the salary savings and end of year sub-grant payments that'll be made during June. So look at those. Is there any questions on the expenditures? Okay, so moving on to the third page is the summary. Says so this is the list of our restricted and committed funds, and all the programs are listed there and what the balances are that are remaining. And as you get to the bottom, the cash that shows the cash requiring additional commitment, the 613,000. And our expenditures in May were a couple $100,000 more than the revenue, so I expect that to happen again in June. Once all of the payments are made before the end of the year. And this will leave us with a balance of around 300,000, which is what we expected to have due to the revenue that we collected this year that should have been collected last year. We were behind in drawing our federal grants and some of our sub-grant billings to help them out. Do we have any questions?
Any questions? Thank you.
Thank you, Chairman.
Okay, go on to the next, which is contract services and grant applications. Michelle?
Yes, we did not have any contracts or grant applications over 50,000 during the month of May.
That's an easy one.
That was an easy one.
I already saw that. I'm stuck. Hey, thank you.
Thank you, Chairman.
Next on the agenda is Board of County Commissioners confirmation of term renewals. This is for information.
Commissioner Purdy's confirmation.
Yeah, we already,
Yeah.
that was already pretty much taken care of.
Yeah.
Do we need to have a formal vote on that or not just?
No, it's just informational because each of your boards, county commissioners, commissions voted.
As you know, Commissioner Purdy was selected by the county, Adams County Commissioners to serve on this board another term. So, all the counties have already signed to approve that. So,
Mr. Chair,
Yeah.
I would like to mention that due to an error on my part, it's still in process with Washington County. I did not get that email sent when I sent the other clerks due to an error. So I did communicate with her yesterday, and that will be on their agenda for July 6th.
okay.
So her confirmation is still in process. However, due to the statutory requirements, and I meant to tell you this yesterday, Nikki, when I realized, so she's smiling at me. Newsflash. Thank you for the sudden news flash. Due to the statutory requirements that the majority approve her, she's already approved, but I am still waiting to receive that Washington
Okay.
County ballot. So thank you for that. My apologies.
Okay. Thank you. Those are all surprises. That's good to know.
It's an okay one to have, to be honest.
Yeah.
Next on the agenda is September 2026 Board of Health meeting date revision. Because there was a conflict with IAC, I do believe.
Yes, correct.
We need to move that date. I remember looking at it. I don't remember.
IAC is scheduled for September 22nd, which is actually, one moment, please. Let me confirm. Given my tendency to mess it up lately. Hang on here. Idaho Association of Counties Winter Conference. I'm also confirming our September board meeting date real quick. Our board meeting is scheduled for September 22nd this year, the same date as IAC's conference. I'm not seeing on the website, but I just saw it when we were doing the agenda. Here we go. Their annual conference is September 21st through September 23rd this year. So we could move the Board of Health meeting either a week early or a week late, because this year there are 5 Tuesdays in September.
To the board.
That would be September 15th or September 29th.
You know, when's the October meetings? Present.
Sure. The October Board of Health meeting this year
27.
is October 27th.
Is there a fifth Monday? And
There are
In
4
September.
Mondays in September. Only 4.
So if we moved it a week late, we would still be 4 weeks. from
Yeah,
the next
that's
one.
gotta be.
Sometimes they end up getting squished together. Yeah.
9/29. Perfect. Thank you for that.
Later's better for me. Maybe in Montana the second week. Hopefully. Birds.
I should still be here, not in Arizona. Maybe the next month I'll be in Arizona.
In November.
I usually go the first week, but they changed the law this year.
Okay.
No
So we did move it?
for the first 10
We
days.
did move it. It is listed as an action item since that was.
That is a formal motion.
Yes, please.
Mr. Chairman, I move that we move the September meeting from September 22nd to September 29th.
I'll second.
Been moved and seconded that we move the September Board of Health meeting from September 22nd to September 29th. Any discussion? Hearing none, all those in favor? Aye. Motion carries. Thank you. Next on the,
So I can introduce, these are guest speakers.
okay, go ahead.
And we're really far ahead of schedule, but I see that Boydana is on. So, and Jathan's sitting here behind me. So I asked, we all back up a little bit. We've been, as you know, kind of analyzing potential opportunity to expand the work we're doing in Washington County with behavioral health, community care medicine, and looking at different models that might work, and also trying to understand the needs. And one of the things that we've been working on is with state EMS to kind of understand who's using 911 and what kind of conditions are they presenting with, and what kind of opportunities maybe would exist for the health district or EMS agencies to look at kind of a different model of care to help reduce the non-emergency use of 911. So we've been working with Jathan, who's sitting here with me, and Bojana, who's online, and we asked them to present some data that they have pulled for us and analyzed on our health district. So I don't know, Beth, is there anything that you want? Okay. Beth and I've been working on this together, so I asked. So Jathan, I don't know if you want to stand up, sit there, sit here. You're welcome to come anywhere.
Yeah. Just a quick introduction. As Matt says up there, I work for the Idaho Military Division in the Emergency Care Systems section of the Bureau. Before I did that, I've spent my entire career as a paramedic in multiple states, done pretty much everything that you can do as a paramedic. But I'll let Bojana introduce herself now. She's got a lot more alphabet soup behind her name. So.
Hi, everyone. Good morning. Thank you for having us. My name is Bojana Morawski. I am an epidemiologist at the Idaho Hospital Association, where I work primarily on two registry programs. One is the Cancer Data Registry of Idaho, which collects information on cancer diagnosed among Idaho residents and has been doing so since 1969. And the second program that I work on, which is more relevant for this topic, although the data presented here are not part of the TSE registry and belong to the EMS Bureau, but is the time-sensitive emergency registry, which collects data on stroke, ST elevation, myocardial infarction, and traumatic injury that is treated or that are treated in Idaho hospitals. So I was asked to help out with this project, and I'm happy to be here. Would it be possible for me to share my screen? Because I added some slides. If it's not, that's fine.
I think we can figure that out. 1 minute here.
Just try to share and see what happens if it lets me.
Yes, I just need a minute to consult with our virtual moderator. He says it should work.
Okay, I'm sorry. I'm sorry for the last minute. You guys are flying through your agenda, by the way, so it's early. But okay, let me try and share this. Which one am I sharing? Great. Okay, so you should be seeing, I think, similar to what you had before, high EMS utilizers in Southwest Health District. And let me try and advance. I'm going to turn off my camera. So just a little bit of background, from the Rural Health Information Hub and kind of the literature generally in the US, about 5% of patients account for 25% of emergency department visits, which is not necessarily what we're talking about today. We're just talking about EMS calls, but those things are closely related. So these patients also called 911 for a range of medical and non-medical needs. And as you might imagine or know, they frequently have complex health issues that are layered with social, mental health, and or other resource needs or lack of resources. So high EMS utilizers may be particularly challenging for rural areas, which is especially pertinent to Idaho, obviously. Fewer primary care and specialty providers, services that are less available on evenings and weekends, and EMS agencies that are staffed with volunteers. High EMS utilizers may benefit most from care navigation and resource referrals to help stabilize their health, but traditional EMS providers who are being asked to do these things when they do go to, or when they do respond to these high utilizer calls, traditional EMS providers are not necessarily the best suited to provide these types of services. So Nikki and her team asked us to look at what EMS high utilizers look like in Southwest Health District specifically, and we do have some county-specific information, but a lot of this is just an overview of the public health district. So we defined high utilizers as individuals who called 911 for EMS at least 3 times in 3 months and or at least 6 times in 6 months. And just a note, we excluded any EMS calls to healthcare facilities. So if someone called for a pickup from a SNF or some other type of, medical transport from urgent care to a hospital, those types of calls are excluded from these analyses. Because we really wanted to look and see what was happening kind of in the home or in the community. So high EMS utilizers in Southwest Health District during 2023 to 2025, we identified 53,531 EMS responses, unique EMS responses. So this required a little bit of work because, as you know, it's not uncommon for multiple units to show up to a scene. So 53,000 approximately unique responses for 46,562 individuals. There were 509 people, or about 1%, who were identified as being high utilizers. And again, those are those people that are calling 3 times in 3 months or 6 times in 6 months. And these people were responsible for 10% of EMS calls. So these 509 people were responsible for 4,684 calls in this 3-year period. And I have this graphic, which is not, the labels aren't showing up for some reason, but we'll just move through that. I think the blue here are the super high utilizers. So the 6 times in 6 months, and the green is 3 times in 3 months. And I think it's about 0.3% and 0.8% respectively. But you get the idea from the other information on the slide. So over 1 in 2 of these EMS calls among high utilizers resulted in transport to an emergency department, at least. And this is based on the data, which Jathan and I haven't had a chance to touch base about this yet, but it could be more than that. So this is by provider primary impression. So of these, and there's a lot on this slide, of these calls that resulted in transport to an emergency department, 100% of them that were OB-GYN, 100% of them that were sepsis resulted in transport. And then really high proportions, I would say overall, for most types of provider primary impressions or most type of health events. Just going through this, pain, 70% resulted in transport, respiratory, so that's anything from shortness of breath to COPD, 67%. And then down here on the lower end of things, we have this general weakness, sick person category, which is one of the most common types of primary impression, and less than half of these people resulted in transport. When there were no findings by the responders, only 4% were transported. And please jump in if you have any questions. Or Jathan, if you want to add anything, please jump in. So this is the burden of high EMS utilizers by county. So this is the number, this is a crude rate per 100,000 population. So we're not adjusting for age, but these are the number of people divided by the population in each county that are high utilizers. So we have kind of the lowest rate of high utilizers in Washington County at 40.6 per 100,000 population, and the highest in Gem and Payette counties at around 55 or 56 per 100,000 population. So just to give you an idea of how these high utilizers, when accounting for the underlying population, what kind of the rate or the burden looks like by population or by county.
Can I ask a question?
Yeah.
Is the number in Washington County low because of the community paramedics program? Do you think, would that be higher if that program wasn't in place?
I'm going to let someone else speak to that question because I don't know.
Well, I don't think so, because this is 23 to 25 data, right?
Is it? Okay, so this is before that.
Been like a year since we've been in, correct?
Yeah. So there's only part of a year.
Yeah.
Year period.
It's a great question, though. So this shows time in service. So how long was that unit out on their call? So time in service by EMS user type. So this is again there's a comparison group here in gray, normal use. So that's less than 3 calls in this 3-year period. And then the short-term high utilizers, again, this more than 3 or more calls in 3 months. And then the longer-term high utilizers, 6 or more calls in 6 months in the dark purple and light sort of purple color. But then the gray is just this normal use reference. So time in service by user type and county. And for me personally, I don't see a lot of patterns here. There's a lot of variability, but I think it's hard to say consistently, the long-term high utilizers are requiring longer calls than, a quote unquote normal user, et cetera. But, the median time that EMS is out for any of these calls is, from about half an hour in Canyon, Gem, Payette counties to closer to an hour in Adams and Washington County. And then again, this is by county, EMS calls resulting in transport for high utilizers. And again, we have this comparison group of quote unquote normal use in gray, and then short and high term utilizers in these purpley colors. So the vast majority, and I will caveat some of this by saying the numbers here for Adams and Washington County are kind of small, but there are a lot of transports in this short-term or longer-term high utilizer population. So 100% of those calls are being transported in Adams County. 100% of those calls are being transported in Washington County, Owyhee County, Gem County, very similar. And then in Canyon and Payette County, less so. That said, there aren't that many real differences from normal users, just to say that, this resources are being expended for these high utilizers, and maybe those resources could be kind of put elsewhere maybe. And we started talking about EMS provider primary impression, and I should have put this slide, or we should have put the slide sooner maybe, but just to give you a little bit of a background or more specifics on what EMS provider primary impression is. So it's the paramedics or the EMT's working diagnosis of what is wrong with a patient. It's kind of considered a medical best guess, because in the field there is limited diagnostic information and potentially limited information from the patient. And Jathan, I think you were going to take over at this point, so I can just advance the slides and maybe you can talk a little bit more in detail about the key drivers.
So yeah, to provide a little bit of clinical background here, what do these patients look like, the high utilizers? And the biggest drivers for this was pain management. Lots of patients, lots of these were calling 911 simply for pain and to manage that pain. Weakness, that is kind of a generalized term. A lot of times you'd have no idea what's going on with that patient, but they're just saying, I'm weak or I'm dizzy and I need to go to the hospital. There's not a whole lot of information there to determine, well, why are you weak? Is this weak due to a chronic cardiac condition? Is this weakness from, whatever else? Dizziness, is there something neurological going on? Well, we don't know. But that's kind of one of the more generalized terms. And administrative and non-clinical, this has to do a lot with lift assists. Patients who cannot get themselves up off the floor. They, have chronic conditions. Typically, nobody lives with them, or the people that live with them are not able to get them off the floor. It ties in with weakness, and it also ties in with obesity, and those patients not being able to get off the floor. And so 911 or EMS has to go out there and get them off the floor. And typically there's not a transport for these because they're not typically wanting to go to the ER. They just want to get back in bed or get off the, get out of the restroom or get back in their recliner. Respiratory issues. These are kind of big. And typically when we go out, even if it's a high utilizer, these patients tend to be more sick. But it's typically due from chronic diseases that have not been well managed. You've got COPD, CHF, there's a lot of different issues that cause respiratory distress. And these tend to be more of the emergent calls that we do for high utilizers. It could be anything from asthma exacerbation, which is a chronic condition like COPD, and a lot of them have just either been non-compliant with chronic disease management, or they have run out of the medications they need. They're on oxygen tanks at home and the oxygen is empty. They're out of, their inhalers. And they've waited for the last minute, till the last minute to call 911. So typically when we walk in on a patient like this, they have waited till the last minute where they're literally can be suffocating. And so these do turn into legit calls, but like I was saying, it's usually due to mismanaged or non-compliant chronic conditions. Injury and trauma. This is another biggie. And it also ties in kind of to the administrative and non-clinical, lift assist, but a lot of times we go out to these patients and they're seriously injured. They either just had a knee replaced or something and basically destroyed their new knee, or osteoporosis. Elderly patients is typically what these are, and we all know that ground level falls among the elderly population is the number one killer. And these patients are typically they need attention in the moment. And behavioral and psychiatric, these are their mental health stuff. They're having some type of psychiatric episode. They have been non-compliant with their medications and their treatments, and they're in crisis. And unfortunately, with these types of calls, if they're not managing themselves or having somebody manage their care routinely, they will have behavioral crisis, psychiatric crisis. And a lot of times we have to go out there and either calm them down, or sometimes even medications to help sedate them. And those pretty much all get transported as well. Did I kind of cover what was in our notes there on this slide, Bojana?
So, are there any questions?
This has been one of the division administrators. I do have a question, and I was wondering about if there's additional data on how long these high utilizers stay that way, whether either they are end of life or if they go to a higher level of care, or what's the
How does that? Yeah, I can take that on, and Bojana may have something to add. So there's a couple, like behavioral and psychiatric. They're gonna be that way for a long time. They're typically your younger, middle-aged patients who really do not have access to the care that they need to manage that. And so they'll continue the calls. People with respiratory tend to be more end of life. They got a few years left and they're trying to manage their condition until they're no longer with us. And pain management. I don't have specific data on this one, but I've been out to 1,000 of these calls, and they're typically younger And a lot of times they suffer from addiction, or they're seeking pain medications, they're drug seeking behavior. So it kind of runs the gamut. Anything you want to add there, Bojana?
So can you actually repeat the question? I'm not sure that I heard the whole thing.
Yeah, I was just wondering about how long these utilizers kind of stay as high utilizers, whether they're
Okay,
able
yeah.
to apply for into a higher level of care, or like he was just saying about behavioral health, maybe they're kind of long term.
Yeah. I mean, I think Jathan described it really well. I think we do have, or we could characterize the specific amount of time that any given person by primary impression type was in the system, or, calling EMS, I guess not in the system, but in terms of referral to higher level of care, we don't necessarily have that information on if they're connected to other services. We do have some data in the trauma registry for some of these injury patients, which doesn't really speak to the behavioral and psychiatric piece of things, but we do have their trajectory. We have the ability to see if they're transferred to tertiary care, out of state, et cetera, and then how many times they are receiving inpatient hospital care. But that's a little bit different than the question that you're asking.
Sure. I was just thinking of the subcategories, how a lot of them you could assume maybe
Yeah.
respiratory or the generalized weakness one even.
I would say that the injury and trauma, including ground level falls or people, populations at home that fall a lot. I mean, these are typically what get called. And that's one of the biggest ones that end up in assisted living or so and they're typically, I think I said earlier, your elderly patients who clearly they have equilibrium or balance issues, and weakness, and they'll fall and they'll hurt themselves.
Yeah. And I would just add on to that similarly in the trauma registry, by far and away, falls are our most frequent cause of hospitalization, death, or transfer to a higher level of care. And that, like Jathan mentioned, it's in that elderly population. So, anything that we're able to do to preempt that in the home would be, although it's not necessarily entirely occurring in the home, some of it is in assisted living, which is unfortunate, but anything that we can do to preempt some of that or prevent it would be a real boon to our healthcare system, I think, and our patients.
You mentioned joint replacements, and they seem to be easy to hand those out at an elderly age, which is great, but because there's a lot of good reasons to have it. But I wonder sometimes if they address the issues of why they get a joint replacement. I mean, I know my husband had a hip replacement when he was in his late 40s because of fucking bales, but he was also in really good shape and not a pound overweight and ate really well. So we get a joint replacement, but we don't bother to address some underlying issues, and particularly physical therapy. They don't even do physical therapy. They just send people home anymore. And when my husband had his, he was limping by that time. So I said, if you're doing physical therapy, we have insurance for it, you're doing it, but they don't even want to do very many sessions anymore, even on a Cadillac plan. I think it's like 10 or something a year. So just throwing that out there for something maybe to address.
That's correct. And they're doing them in outpatient surgery centers and not even keeping them overnight.
Right.
But having run a bunch of those calls as well, to address what you said, most of those have joint replacements that have resulted in 911 getting called from an individual who was not very mobile in the first place. Right. Could be a variety of conditions why they weren't really mobile in the first place. Sure. But there's so much other stuff. It's not like you're gonna go out and walk around the mall or in your normal state of health. But they like giving those out like candy and but that's another subject.
Right, right. I just want to bring it up because it is kind of relevant.
Yeah. And just to, to highlight quickly some of the limitations of these data, just to say that the primary impression, the administrative data from EMS agencies can be incomplete. EMS provider primary impression may not match a final diagnosis and can lack specificity for the reasons that we mentioned before. And I will say that because we did not have the bandwidth to do, a really granular human level review on all of these potential matches, the numbers here likely underestimate the problem. And I will also say that we do have by county the primary impression for these high utilizers. So you can see for your county what the most common primary impressions are. But thank you. And then here's our contact information at the bottom, but I'll leave it on this slide if you're interested in looking at information for your county. And happy to take any other questions.
Well, Jenna, can you go back real quick to the slide where you listed the major primary impressions?
Sorry, which one? This one?
No, the one I think it had 5. Yep, that one right there.
Yeah.
Yeah, so just to throw in a caveat from kind of the clinical aspect of having been in the field a long time, where I can see Kim's making a pretty big impact on these drivers right there is in respiratory issues, injury and trauma, and behavioral.
Mm-hmm.
And because respiratory issues, that's due to mismanaged chronic disease. And you can blame that on lack of resources or, lack of compliance. But if respiratory issues for chronic reasons were addressed systematically, I would think that those numbers would go down until at least we wouldn't find so many people in absolute crisis when we go out there. And injury and trauma, we've got fit and fall proof. A lot of times you can help them, offer, safety equipment and checkups on and all that kind of stuff. And behavioral insight. I understand that's already underway in one of your counties and seems to be doing well. But that's another mismanaged mental health disease that if you come off your meds or don't do what you're supposed to do or don't go to therapy, you're going to have another 911 because, again, you'll get into crisis again. So I just wanted to make that quick point.
I would think that pain management would be another one.
It can. Those people typically either we don't give them anything or we give them narcotics. And some of those patients kind of know that, and they can be, have a narcotic addiction, or they run out, or just can't get them because they're on a pain contract, they don't have their medications. And so those kind of can run the gamut. Typically, what I don't see is going out on a 911 call to a patient, in the elderly population, or that just had a joint replacement or, stuff like that. A lot of times they manage their own pain. They do pretty well. And the ones that I see are not in that population, and it's just generalized.
It's more
pain. They know that we carry other things to help manage that.
So they maybe need addiction treatment, but we're not gonna fix that.
I wouldn't say all of them, but a solid proportion. So, any other questions?
I have maybe just a question, Jason, since we're kind of, looking at kind of some innovative model to try and build capacity in EMS, understanding that like health districts not,
Mhm.
we're not emergency responders, but we want to help support our emergency responders with kind of the non-critical, non-life-threatening things. And I'm just curious from your experience of having worked in other states, what kind of capacity that, I don't know if you can really answer that question.
Yeah.
I'm just trying to think about what might be helpful for our board members to hear, since many of them also sit on ambulance districts. What kind of capacity are we looking at? Return on investment potentially with something like that.
It depends on what you're looking at for your return on investment. Are you looking to decrease 911 calls and keep the ambulances in service? Or are you looking to continue to support that revenue? Because one typically will cancel out the other, unfortunately, because if you call an ambulance and you get transported, that's payable, at least payable in a decent amount that makes your trip out there worth it. If you don't transport and you just go out there and fix the problem where it's at, you spent just as much time with that patient, but there is no revenue. So it's kind of a balancing act. And we want to stop these 911 calls to the hospital, who then get ER admission payments, or do we want to keep them at home, not get any financial return, but them not call? So it's kind of like pick your poison. At least in the EMS and ED arena. So KIMS can lower 911 call volume, but then there's dollar signs associated with that. And as an EMS provider myself, who I get paid by the hour when I'm on the truck, I don't care. You know, it doesn't matter to me. And a lot of these patients, especially chronically mismanaged or non-compliant patients, are sick where they couldn't have been.
So which, if you could zero in on calls that are less often to be transported, that could be treated in a different way, which ones would those be the ones that you talked about, that category, or?
Well, the lift assists, or, you know, community assists, go out, you know, helping somebody get back on their feet or get to where they need to be. That's one. Sometimes the pain management calls could be.
So those are different. That's a whole different set than the other ones you talked about.
Which ones you want to jump back to that slide again?
Sure.
Let's
Yes.
slide with me.
You can do. Give me a second. I also see that you folks have a handout, and I'm sorry, I've changed the slides since then, so I will send this deck to Southwest District. Let me share my screen again.
So I guess the biggest thing on there would be behavioral and psychiatric. Those patients are not fixing to die. They are just off their meds. They're having a mental health crisis. And if we transport those patients, those are quick to get discharged and sent right back home. Because you transport them to the ED, they may, you know, give them a dose of medications and send them home because they're not at death's door. That would be the biggest one that I see. That kind of answer your question? Or
Yeah, I guess I'm asking because you said the respiratory injury, trauma, and behavioral and psychiatric could best be handled separately.
Correct.
But which one, if you look at the ones that could be handled separately that maybe are not resulting in transports, it's a different set.
Right, there is.
Because that is a big part of our model.
Right.
Is the funding piece of it.
Right, right. Well, the respiratory issues are always going to get transported. Behavioral health and psychiatric, depending on how big of a crisis they're in, they may get transported. If we give anybody any types of medications, they're going to get transported. So it's kind of hard to narrow those down and as to, without more data, which ones don't get transported as often.
And our goal would be like, remember, these are individuals that are calling at least 3 times in 3 months or 6 times in 6 months. And so it would be more like coordinating with our EMS partners. This person's called, one or two, at least 1 or 2 times. Yeah, and then trying to intervene when they're willing so that the subsequent calls don't come because then they are in that situation where EMS has to make a call for transport. But if we're managing their care better or helping with fall prevention or substance use treatment or mental health supports, that's where that 911 call doesn't come for a non-emergency situation. And then that frees up EMS to respond and transport the true emergencies. It's kind of along the lines of where we're thinking, but there are some unintended consequences of trying to provide people a better path in their health, and that's the lost revenue potentially if you're especially if you're small. I think it might make it harder.
It's a catch-22, isn't it? Because if you're in a county like ours, for the commissioners, we're the board and we govern them. When they go out on a call, and if it's a fall or something like that, they help them up and they don't get paid. But as far as trying to run a business and make it work, you don't cut it. So I'm not advocating throw them in, taking them to town, because especially if they don't have any insurance or anything like that, then that just sends you down another rabbit hole right there of collections. There's many fingers in the pie on the deal.
I think you're on the right track. I think if we can reduce, our biggest challenge is having a lot of volunteer force. Those 3rd and 4th out calls are very problematic because we have to call in reserves to do those calls. So if we can eliminate some of that, I think in our county at least, that would be helpful. If we can do that by focusing on those calls that truly need an emergency service versus those that can be managed through a community paramedic or some other program, I think that would be a good path.
I think both are important because I know ours is so overtaxed that they can't answer everything. So they end up calling a mutual aid. And either way, they're not getting, they want to, I think it makes the most sense to do the calls that are going to have to be reimbursed at some level. But I can see a different kind of intervention being useful for each one of these categories.
And a bunch of them are just experts in care navigation, which is what a community health EMS provider, whether it's community EMT or community paramedic, a big part of that is care navigation. And paramedics like me, I'm not a community paramedic, just a 911 guy. But they have special standardized training on care navigation and management of chronic diseases. I don't. I fix what I find.
Yeah.
And so that's what I think would help. And you were speaking about revenue. I don't want to get in trouble for saying this, but the typical KIMS model that's been in place for the last 20 plus years is not financially sustainable to go to its peak. And now we're starting to integrate mobile health, and with actually physician-backed mobile integrated health, and that is a source of revenue, especially if it was tied directly to KIMS. KIMS is the hand-on, the physician is actually, basically it's an in-home doctor's visit that is. So blending those two, I think, would be the next way.
See is the role of the dispatchers in all of this.
I like emergency medical dispatch. We call it EMD. That is when the dispatchers are actually medically trained, and use programming to ask more in-depth questions. A lot of them can refer to KIMS and say, no, doesn't sound like you need an ambulance out here. Or they could be telling you how to put a tourniquet on, or, that they have, and they're managed by a medical director, a physician who's all over the calls. So E&D would be awesome. And I wish every county had it, but there's only a very few counties in Idaho that have it. And they're more, the larger metro areas that have it. And
Canyon have that?
I've never even heard of it. Yeah, I believe Canyon does.
Because that
Canyon has it.
Canyon's numbers are a lot lower too, it looked like.
Yeah.
Some days.
So that would be a big help. And actually dispatchers could help navigate that, or at least inform the responding agency that, hey, this is what I think you're walking into. Might want to make a KIMS referral.
Jacob, can you confirm then? So it sounds like this is a question I've had, because I've heard word on the street that if you call 911, they are required to send like an ambulance or fire or whatever. But what I hear you saying, I think, is that if someone calls 911, the dispatcher, and they're appropriately trained and whatever,
Right.
can triage and say, oh, you need mobile crisis, you need urgent care, or you need an ambulance.
Yeah, or, there are different options, and it kind of depends on what the rules and regs are at the local level.
That's not a state statute.
The state rules, the data rules, say that a 911 response agency must respond to 911 calls. But the agency has to respond. Is it necessarily a KIMS provider? Is it somebody going out there and a lot of times it's law enforcement. So it's kind of the policies of the dispatch agency, how they want to deal with those types of calls. I would say most of the time, if it comes in via 911, vast majority of time, ambulance will go out there, and if the agency has a strong KIMS program, the KIMS provider will go, especially if it's on a well-known, we've been out here 6 times, and we know what we're going out there for. Then, some on-the-spot decisions can be made.
That's not happening at the dispatch level. That's happening after it's been dispatched.
Well, dispatch, again, it kind of depends on where you're at, and what the local dispatching policies are, how the sheriff wants the dispatch center to work.
There might be some opportunity there.
Might be.
I have another question, maybe it's more HIPAA and logistics related, but if we know the cohort, we know these people, we obviously at point of care is not always the optimal time, especially when we're trying to do prevention work. Are we allowed to get like lists of these folks and reach out, or is someone, because there's HIPAA rules are kind of funny where there is some implied consent depending on what's happening, but not always. And I don't know how it works with prevention, but if we were trying to intervene from a health district's point of view, we do our work before this happens, not when you're doing your best work
Right.
at the time. And so I'm just wondering what the rules could be that would allow us to, here's 500 people and we're gonna call them all and say, hey, what kind of resources do you need? Try to prevent that, because we're assuming that we're talking about ambulance and resources, but probably these folks are sucking up other resources too that could be addressed and would be helpful. that aren't getting captured even in this conversation.
Good. Care coordination under HIPAA would be allowable,
I would think so.
and maybe we would need consent EMS to initiate and then get consent.
Yeah.
To return.
So I'm not a HIPAA expert. Just know to keep my mouth shut about my last call, so.
If I may, I think one of the things that you're talking about is really important, right? Because in the field, we have very limited choices. We can take them to the emergency room and convey this is what's going on. And then we have the cycle that's already been talking about. The emergency room's just going to treat the right here, right now, send them home. Cycle continues. We have, okay, we've been in this position multiple times. Now we're doing adult protective services referral, which seems like it's now a further extreme, right? But if we can get the services that you're talking about in the middle, we have now something in the middle, right? The field personnel know who they want to refer to you. I guarantee you, they know exactly who they want you to call. It's about opening the door for that something prior to adult protective services, and the emergency physicians would love to have you involved too, because they don't want to see them bouncing back over and over and over again either.
Yes, 100%.
In places where they do have a CAMS program that's functioning for a long time, how do they pay for that? Is it just continual grants or?
The most sophisticated KIMS program in the state by far is Magic Valley Paramedics. They are part of the St. Luke's healthcare system because St. Luke's runs the 911 agency in Magic Valley area. And they are directly connected. They're part of the same system. They're hospital-like. And one of the reasons they are so successful with KIMS is because they also use a lot of mobile integrated health being a part of the hospital. And it's a lot of times it's physician supported. I don't know, have you guys heard of St. Luke's Hospital at Home? Yeah, that's another really strong, but again, it's St. Luke's. So all your providers are St. Luke's employees connected to the largest healthcare system in the state and access to all of that. And so revenue, I guess, I'm not sure how much goes back into the operating budget of Magic Valley Paramedics. They have their own, disbursement of funds, but it's within their system, and they're the best. I could give you a bunch of contact information for friends I have over there who do that work, and especially if other agencies over here want to expand into that role, they would be a massive resource.
How that would. And some of the challenges that I hear are with retention of paramedics in our counties. And I don't know, with a St. Luke's partnership, if that would be mitigated, but I feel like that's one thing that we run up against a lot. And then even just getting a community paramedic, if we went with that model, we had that now in Washington County, but looking at what the patient's needs are and what our resources are, we actually think we could use a lower skill level provider to meet a lot of the needs.
Mm-hmm.
Yeah. So.
What else can we answer? Okay.
Okay, thank you so much. Any other questions? Anyone? Thank you so much.
Thank you, Virginia. Thank you.
Thank you. Okay.
It's time, we'll take a break. We're going to go into abatement of nuisance. It's very much pain.
Thank you, Mr. Chairman. I got, your executive director a month ago, and I was asked to take a look at kind of the world of abatement and the world of injunctive relief and what sort of things are available for you. And after kind of researching the issue a little bit, I kind of I called her and said, well, give me an example. Really, what are we actually talking about here? What's the main problem? And the way I understand it from talking to Nikki was that it's primarily the people who are setting up a trailer or mobile home or something, and maybe sometimes even in groups, and not having proper septic. That's what I'm saying the central issue is. But obviously there are other kinds of issues that can crop up that you might face. So I kind of took a look at what we think about what exactly abatement of a nuisance actually is in Idaho. And I'll be honest, I had a case when I was a young prosecutor, like 40 years ago or more. And that was the last time I dealt with an abatement of a nuisance. So I kind of went back and looked at what the law is. And I was a little bit surprised, quite frankly, on how vague and limited nuisance law is when it comes to governmental entities. Yet your statute tells you you can abate nuisances. So just to give you a general idea, I gave you the statutes here, and I guess they're going to come up here, and you probably can't read it. But what surprised me on nuisances was how vague the law is. It uses glittering generalities like anything which is injurious to health or morals or indecent or offensive to the senses or obstruction to the free use of property. And that could cover almost everything in any given situation. But then when you look a little closer at, there's different kinds of nuisances. There's private nuisances between two parties. The neighbor turns his front yard into a junkyard, and you don't like that, and you can do something about it, and that's a private party. There's a whole section of law called moral nuisances, most of which have not been worked on for maybe 100 years. I went back to the cases in speakeasies in the 1920s and gambling dens and porno houses. And so that's a wholly different area of the law. And then there's this thing called public nuisance, which is on 102. And a public nuisance is one which affects at the same time an entire community or neighborhood or any considerable number of persons. And so when we think about a guy who is not following the rules, which we do here, Ben and I have looked at a few of these, who's, just not, his septic tank has failed and it's too close to a well. That's not what we would think of as a public nuisance code. It's really a one person. Unless, of course, the drain field totally fails and then you've got an entire neighborhood. You could then think of as a nuisance, but not really the best way to go, I think. I think there are other ways you can get to taking care of this. The other thing that I think is probably relevant for you to understand is there are different ways to take care of nuisances, and that's the next thing here. 52.202, what are the remedies? And there are three. One is criminal action. And in most places, most counties, they have their own ordinances that say it's a crime to do X, whatever that might be, dumping dead animals on this kind of thing. It's a crime. I don't know that I've ever actually seen a prosecution. Maybe some of you are familiar with prosecution around these kind of things. I suppose they could happen. Next is civil action. We'll talk more about that. And the third thing is what they call So I looked up what exactly we're talking about by abatement, and what that is if you have a public nuisance, theoretically, a governmental entity can go out and abate the nuisance. And what would that mean? It would mean essentially self-help. The best case that I found in the state of Idaho, at least on this, is guy fences off a road. And the county had the ability to literally go and take down the fence. That's what it's called, abatement. And that would certainly work in certain areas. How it would work in your world is questionable. I mean, it depends on what the situation is. I mean, you're not going to be going into somebody's house and, quote, abating a nuisance unless it's doing something incredibly outrageous, like, again, dumping dead animals or something like that. But not really very realistic for, I wouldn't tend to think, for a health district to engage in some. And again, as I said already, that most of the cases that I'm familiar with are 100 years old. Gambling bans. So, plus on top of that, in the modern era now, we have all these statutes that are very particular about private property rights. And they don't want you to even go on. So technically you can abate a nuisance, but at the same time, you can't go on the property without a police officer. It makes it hard and probably a little bit unrealistic. Just go to the next thing I've got, abatement by public body. A public nuisance may be abated by a public body. Well, great. How do you actually go about that? Is the question. So what I did then was kind of go and look at kind of what the powers of the state entities are around this kind of stuff. And you work very closely with health and welfare. You work very closely with DEQ. So next, I went to Department of Health and Welfare and 56-1003. And this is kind of an interesting law. It's been around for a while, and it includes language that seemingly allows health and welfare to do things to abate what they consider violations. And if you look on the second page here, third page, it talks about the ability to actually go on land, and I'm sorry, it's the first page. But note that while you're with the Department of Health and Welfare, you can go onto people's land, and this is section C. I'm sorry, I'm looking at 1009. These are out of order. How does Health and Welfare go ahead and investigate a violation of their law and rules? And the answer is they can actually go on people's land, but you have to get a search warrant. So if you're with the Department of Health and Welfare and you want to go onto somebody's land because somebody is doing something that violates their you have to, unless it's what they call an exigent circumstance, you've got to get a search warrant. But at the same time, it gives the Health Department of Health and Welfare to get a search warrant to go on somebody's land or property to get the information they need, do something about whatever the problem is. You don't have that ability. But that doesn't mean you can't work with Health and Welfare in the right situation. Jumping ahead, I'll tell you right now, DEQ has the same rules. They literally have the ability to go to a court and get a search warrant to investigate really essentially a civil violation of the DEQ rules. That kind of goes hand in glove with the new laws that basically say that you can't go into somebody's property without permission or a cop helping you, which means you're going to have to get a search warrant. So
That ever happened?
I've never heard of it. I've never in my, doesn't mean it can happen or doesn't happen. I've never heard of it, but it can happen. The best example for health and welfare is the Reportable Disease Act. They have these places where, full of, say, with tuberculosis, they can theoretically get a third point going. So, okay, what do you do in these kind of situations? And you're in a situation where it used to be they could delegate to you. Now they work with agreements with health and welfare. And one of the questions that came up, and it actually is in the law, and that, I think that's 1003 of the health and welfare rules. It allows you to, quote, quarantine health and welfare rules. And when you quarantine house under the rules of health and welfare. The problem is, I couldn't find any rules that health and welfare had that would allow you to quarantine a house other than the Reportable Disease Act. So if you had a situation where the health of the neighborhood, or at least the household, was a problem, something that apparently happened.
Like a year and a half ago.
Yeah. Well, I was on vacation, interestingly enough. Theoretically, at least health and welfare can literally close a house down. And what happened in this particular case was people were pumping sewage into a drainage ditch. You got this right, Vicki?
You want me to tell the story?
Yeah, why not? It's kind of a weird story.
Yeah, their home was being rented to a young family with toddlers, and the septic was backing up into the basement, and the property owner was requiring them, this went on for months before we found out about it, to pump the sewage out of the basement from the tub out into a drainage ditch that bordered two properties. So exposing the family and the pets and the toddlers who were walk to sewage on the ground outside and in the house. So we quarantined the property and then helped the family, actually the sheriff's office helped us get the family to a safer place, and then didn't allow quarantine to be lifted until the septic system was corrected and the home was abated.
Yeah. And what's interesting about that is that's what the statute says. The problem, it also says, based upon the rules of health and welfare, and I got to tell you, I cannot find anything. What I can find is quarantine, isolation, and restricted access around the Reportable Disease Act. So if you're dealing with something like tuberculosis, I mean, you know what to do, and the rules are all there. I don't know what happened, whether they used to have rules, whether the great purge at the state where they got rid of half of their rules, whether that happened, whether they ever had them in the first place. So you should at least be aware that there's a statute that says you can do this, or health and welfare can do it. But it's also tied to rules that I can't find. So it's kind of a weird situation.
So did that give you pause before you did that as to whether or not there was legal justification?
Well, we worked with Mike's associate to do that. Now I'm like, what?
How did you do it?
Well, we drafted the quarantine order.
Right.
So you
We
did
ran
it.
it through,
Yeah.
ran it through
Following the
computer.
statute, my people, again, I was gone, didn't look to see what are the rules and didn't realize that there were no rules, except in the Reportable Disease Act. So I suppose you could make an argument that, well, here's how you do it in the Reportable Disease Act, and that must be what the drafters of the statute meant. In the right situation, in emergency, you got to do what you have to do.
Yeah, but there's other other laws out there on
Yes.
that very issue that you were
Yeah.
discussing. There are other laws and rules that are already in place that you can go in and do.
Yeah,
Because DEQ also has authority over, because you're putting sewage in a drain ditch, which is, the water in the drain ditch is owned by the state of Idaho.
Right.
So you've broken many violations there.
right. And that's where I was actually going next. If you were just-
I was just gonna say the quarantine order is not in DEQ's authority, it's in health and law.
Yeah, I
Yeah,
understand.
but you do have,
They are different.
you do have the ability to do something. And ironically, in the situation that we're talking about here, where you had these people pumping sewage into it, that's really a DEQ issue rather than the Department of Health and Welfare. That I suppose you can make an argument that it's injurious to the health. And you also have statutory authority to take care of filth and this sort of thing. But really the better rules, as you point out, Chairman, are probably the DEQ rules. And that's the most, probably the thing that I think you have the best avenue to deal with these sorts of things. And you're right, DEQ does not say you have quarantine authority, but DEQ, again, has criminal statutes, and you're exactly right, Chairman. I mean, dumping sewage into a draining ditch is a misdemeanor, no matter how you look at it. But also, you have the ability to file injunctive actions, and using the DEQ model as the way to go. And that is what I'm recommending. I'm jumping ahead. I'm not going to go through all these statutes, but the reality is DEQ, in a situation like you're talking about here, the example that we just talked about, has the right of entry. They have the right of getting a search warrant. They have the right to file an action, an injunctive action, and do something about it. And since they are now working with the district, you can key off their rules to basically do these things. You have to work with them to get a search warrant, but you can certainly do injunctive actions.
We wouldn't require them to go take care of it.
No, I mean, you
They would grant us that authority.
Ideally, we'd want to work together, but you can do it that way. And also, then if you're still looking at these statutes, we have specific language in the health districts of laws, 39-419, that allows you, as a district standing alone with or without the help or permission of DEQ, to do the same sorts of things. Primarily, again, it's a crime to violate these things. You'd have to go to a prosecutor, or you can file an injunctive action. And if you look at 39-420, which is here, that specifically gives you the right to seek injunctive relief to take care of filth, infestation, infections, communicable diseases, health hazards, wide open. So, kind of going through all this, what I came to is probably the best avenue you would have for the situations you're dealing with now, which is people who are simply not following DEQ rules, is to seek injunctive relief, either with or without the help of DEQ. Obviously, you want them to help you. And they may have to, and would have to, in certain cases, provide the expertise to sign an affidavit or educate the court on what the rules are, what the violation is, why it's a violation of the rules. And they have in a DEQ a whole series of rules as to what you're supposed to do or not do as to septic situations. And they have this thing called a technical guidance manual that covers virtually the waterfront of, what the rules are, and they're the experts. So in a situation like what we're talking about here, what I would recommend is that you consider bringing injunctive relief, working with DEQ using them as your experts. Of course, Ben is also an expert, but not to the extent of teaching you yet. And frankly, that's the way you do it. So when we talk about what an injunction is, for those of you that don't know, and I imagine all of you probably, it's simply a way to go to a court and say, we're asking you, court, to tell these people to stop doing something. The rules are pretty clear when it comes to injunction. It has to be a real life, real time thing happening. It can't be, you can't enjoin past acts. But if it's a real life, real needs action and it's violation of the law, you can go to court and say, we want you to tell these people to stop doing this. And courts can and do that all the time. As we know in the federal courts, they're always enjoining some state statute or something. The concept is the same. These people are doing X. We want you to tell them to stop. And if they don't stop, what we're asking you to do is fine them X number of dollars a day. So they have these continuing orders that can exist that say, if you don't clean up your mess, whatever the mess is, I'll hold you in contempt in order that you're going to pay $150 a day, $500 a day, whatever the number is. It is actually a pretty good tool. I've used it myself in the past for another client. And really, there's nothing like getting a court involved to get people to take action. So I imagine most of your civil divisions have done something like this one time or another, whether it's zoning laws or something like that. It can happen, and it does happen. The process is not simple. It involves a lot of paperwork and affidavits and drafting of complaints and serving of complaints. In a case like what you're talking about here with where the people were blatantly violating DEQ laws, you probably want to go after the homeowner as opposed to the person who is renting or squatting or whatever. You can go for a temporary restraining order saying we got to stop doing this. And there's a hearing that happens almost immediately. So the court would sign off an order, you would serve it, and you got to stop doing X. And then within 3 days, you have to appear in court and explain why you shouldn't be given this temporary restraining order. You have a preliminary injunction process, which gets the matter in front of the court, a full-blown civil trial, no jury, where you present the facts. And the court, if in the right situation, in a situation like this, what we're talking about, that is a right situation, they'll give a preliminary injunction and they'll give them some time to have a full-on hearing later on called a permanent injunction. But almost always, if a preliminary injunction is issued, it gets turned into a permanent injunction. We don't, if a person has a preliminary injunction issued against them, they've lost the case, absent something really unusual. So, and it can be very effective. And it works. Really what injunctive relief is for. So, in a nutshell, what I'm telling you is don't worry too much about the language that you have in your rule about abating nuisances. Nuisances are vague. We already have state law that says this is what you're supposed to do. We have a state law that gives this district and all the other districts the ability to go for injunctive relief. And that's what I would suggest is your best interview, rather than trying to do self-help or make head or tail of these nuisance laws which were written, Now, the best way to go about an injunctive action would be, rather than putting together all of the paperwork and filing something in court as your first step, you can always do a cease and desist letter, which I imagine some of you have done and your work as county.
Is that similar to like what we do with our notice of violation? Because
Yes.
it's pretty much
Exactly.
the same, right? Okay.
You know, if you don't take care of this problem within the next period of time, or at least show us how you're planning on doing it, because you can't expect sometimes an immediate fix for some of these problems, we will file an action and seek attorney's fees. So,
We did have a situation last week that was more time sensitive. So a lot of them, most of them are not as time sensitive. Property owners acting in kind of good faith once we identified the issue and they're working on it. But we had an issue where someone was living in an RV on someone else's property. They were dumping their black tank into Republic Services garbage can for pickup. And then individuals who were driving the truck, they also cleaned the truck. And I didn't know this, I learned something. They have cameras that see everything that gets dumped into their can. So they have video evidence of this. So in that case, when we became aware of that and the health hazard to the workers for Republic Services, we worked with the sheriff's office and the prosecutor. And then there ended up code enforcement got involved because RV is obviously illegal dwelling properties.
Yeah.
That was like an immediate, this needs to stop now. We're not going to wait 30 days for you to remedy this type of situation.
right. And so, you know, whether you call it a notice of violation or a cease and desist, or it's really the same thing. It's basically saying, here's what the law is, here's what you're doing, we know what you're doing, stop it, or we're going to have to go to court. It's really that simple.
But you can have, even at that point in time, you know, you can also ask them to fix the issue before it has to go to court.
Yeah.
Well, that's what the letter, and that's what we do. I mean, I've got numerous violations in Hawaii County. We're actually on one of them that was officially judge ordered in 2006. We're still working on it.
Yeah.
And it's 20 years later.
Yeah. Well, I mean, when you think of some of the great cases that existed, think of the Bunker Hill cleanup that's gone on for 30 odd years, cleaning up all the lead out of the air. It can obviously be extraordinarily difficult and expensive and long term, but the cases we're talking about, it's really just getting the people off the land that you own, really, at the end of the day. Which I understand. I mean, Nikki sent me a series of questions. Some of the questions are, do we have to wait for a complaint? No. You can do something anytime you spot a problem. Would it be more appropriate to use NOVs? Yes, absolutely, as a starting place. And I don't know if you've seen these questions.
That came up at the last board meeting.
Okay.
But you guys probably don't remember.
Yeah. Any thoughts about a responsibility to abate nuisances under 39-420? Well, you can do it. You can actually do self-help, but it's, in most cases, it's certainly better.
So when does the abatement? I mean, it sounds like you're kind of advising that we don't go through the abatement side of things, and I feel like that's there's situations, another one that I can think of right now where there's an elderly person who owns some farmland, person just put up shop, put a stormwater shed on the property and is living out of it. The elderly person's kind of being taken advantage of in this situation. There's no legal septic system in the stormwater shed that the person's living in, so I'm trying to. Notice of violation went to the elderly person, and still nothing's happened, but they have a couple more days, so we'll see. But we're talking, okay, now when we get to the 30 days and nothing's happened with the NOV, we can still go after the elderly person, but that may not
Well, you could also.
So that's why we're thinking, can we abate this? Is I guess my question.
You can also file an injunctive action against the person. It doesn't have to be the landowner. Certainly, the squatter, so to speak. You can certainly do that. When we talk about abatement, though, you're talking about going in and tearing down a house. It would not be something I would recommend under the modern law that we have, where you can't even go into people's property without the police involved.
What do they?
But in a situation, sorry,
I'm sorry,
They don't have a legal septic system in the storm watershed that they're living in.
but are they defecating in? I mean, what,
Yeah, they're living in the storm watershed. But there's no, like, they have like a little solar power thing they hook up to it. They have a hose from
water?
from the elderly person's home over, so they have water, but from what we can tell, there's no septic system been permitted. The county also hasn't, it's not a legal structure, so there's that violation too. So it's kind of, these are kind of the situations that we're finding ourselves in lately, and that's why I wanted to have the conversations here, because we're trying to figure out where does the county authority best lie? When do they use their authorities? Or when do we use them? Or which one should we maybe not use, like this abatement? Maybe that's something we don't pursue.
Yeah, going onto somebody's land and tearing down buildings is not something that health district get involved in. It is something that I suppose theoretically is available under these weird, vague nuisance laws, but not something that I would recommend. Especially where they knows what sort of violent behavior face or 1983 actions or whatever. But ideally, working with the county in a situation like this, see it like forward. So I while you do have the ability to abate, go in and tear down something in extreme circumstance, sure, but something that we're talking about, I'm not feeling comfortable at all.
Well, and I feel like just talking to our partners in the counties and our staff, like this is one incident that we're talking about, but I'm talking to like code enforcement, like, yeah, or law enforcement even, they're all over. They've got a tour.
Yeah, more commonly, maybe they put in their own very primitive septic tub in the ground, feed some holes in it or something, and hook the RV up to it.
Well, there is a way forward. I would recommend it's the injunctive action. Just don't feel good about sending your employees out to go tear down structures and kick people out of their residences. I think it's not in the modern era.
Private property issues there, trespassing. I mean, it's slippery slope.
Yeah.
So, yes, is it expensive? Yes. Is it time-consuming? Yes. But that's the way to do it. Ideally, working with the county or the city or whichever entity we're dealing with, some joint effort would be the way to go. Something like that.
I think, for us, it's understanding, like, when we're seeing these legal systems and we're doing the NOVs, some of them, like, we're trying to think of, like, what do we prioritize? And what do we really, like, what do we care most about? Like, I've heard there's, like, illegal RV parks that haven't been appropriately permitted, that don't have, the proper septic systems. Is that something that is the highest priority? Maybe not. My sister-in-law is living in the trailer in my backyard. But there is also a lot of people, like on Facebook Marketplace, renting their backyard as their RV spot, appropriate hookups. So there's.
Well, and we can't forget that these are also criminal offenses, and the law enforcement authorities can get certified to investigate it. That is a good angle. And then I come back to statutes give health and welfare and DEQ the ability to get search warrants, and there's no reason we can't work with them to do the ask. Will you help us out? We can't do it, but you can.
DEQ has advised us to work with the county prosecutors first.
Yeah. No, there you go.
So,
Yeah.
So I'm curious, do other counties have an ordinance that prevents living in RVs?
We have an RV ordinance that requires a permit. You can have one. And it has a limited duration, and then after that, you have to have a permit to have it on your property. And the purpose is to ensure that you have some plan. It doesn't have to be a septic system. You can have a container that you then take to a, an authorized dump station. But you have to have a permit over, I think it's either 30 or 60 days. I'd have to go back and look at that.
You enforce that?
We're trying. And I will tell you that we have a new code enforcement officer who's retired law enforcement. And we have long been a complaint-driven code enforcement county. But that's not working anymore because people are taking advantage of that. And he has contacted DEQ when we have septic type issues where we have groundwater or septic issues. And they've been very helpful in working with him and our prosecutor. So it's getting better, but it's a challenge. The RV thing is a big problem. And we do have an illegal RV park that happened during COVID. They supposedly submitted their paperwork and just went in and did it. Yeah, so we're working on trying to now make him compliant so that he have a permit for he needs a special use permit or a conditional use permit. So it's a challenge. RVs are a problem. And it's because of the cost of living. Either the person is trying to make additional income by having a renter, or they have family members that don't have a place to live. So they're like, park your RV in the back and you can, stay here. That's kind of why I asked the question. We have another loophole in our county. You don't have to have a permit for a structure. I think it's up to 10 by 12, 120 square feet. So we have, sheds popping up that people don't have to get a permit for. And then they get a permit and have some electrical put in it and, put a mini split in it and somebody's staying in it. We have these little multi-generational camps popping up. I don't know if you're seeing those out where you're at, but yeah. So they have one main structure and then they have all these little sheds that don't require a permit. So it's a loophole.
It doesn't violate the zoning laws?
Oh, well, that's a good question.
Maybe build them as an ag building and then do their own work.
We've had that too. But these are just because it's not required to be permitted, they don't even have to pull a permit. They can go buy a 10 by 12 shed, park it on their lot. As long as they get the power permitted through the state and, if they put HVAC in, they have to have that permitted through the state. It's not illegal because it doesn't require a building permit. The question is it a dwelling or not? And does it violate that? So there are a lot of little nuances to these issues.
Well,
How do you deal with it? I mean,
any case that you would have nuances that would have to be dealt with. But the ones that you're talking about, I think it's pretty clear they're violating DEQ rules.
Yeah.
Pretty clear you can do something about it. It's just a question of where do you start? Who do you pick on first? If that's the will of the board.
Well, I've come to the point when it comes to this, right now, where we're at politically, whether you agree or not agree with it, until there becomes a major, which I already believe there is, but until it becomes an actual health thing, and I just see it continuing to happen, and nothing's going to be done about it until there's something major. I mean, I got two commissioners sit there and say we don't have a problem. And yet I've got court orders for a place that's been in prison since 2006 that has never been followed up and taken care of. So yeah, I just don't. At this point in time, I just think there's going to have to be a catastrophe, and then it'll all change again. There'll be some major disease come through, and it'll just spread like wildfire when it goes to these joints, and then it'll be all over, and then all of a sudden, gotta take care of it. I mean, we can't be proactive.
So I guess I'm wondering, where does it, or how do when is it a county issue and when does it elevate to its health district issue? Or is it just whoever's attention it comes to? The ones that you've had, were they brought to your attention by neighbors or?
We get both. So we get complaints from neighbors often. Sometimes it's the renter. And then we also get code enforcement when we bust in if they become aware, or the sheriff's office. So we get them from all different places.
Because the sheriff's office could take care of it too, right? Or
The county civil.
Sheriff won't.
Do anything.
Yeah, I would say like usually it's handed over to us, then we start with the notice of violation. I think where we're starting, well, there's so many for one, and we don't really, like the same thing as what you were saying. We're primarily complaint driven.
mm-hmm.
If we actually tried to go out and address the ones that we see that are in violation, we would need people.
Army.
That's part of the problem.
So there's that, but, and then, the follow-up after the notice of violation, because I think that's the other piece that, do we wait? Well, none of us are probably gonna be here 20 years, so, but do we wait 20 years in this situation?
Well, I would think, septic issue falls squarely in your area of responsibility, right? I mean, you issue permits for septic and approve them, approve the installation.
Yeah.
That's really not a county function, right? We rely on that certificate from whichever health district you belong to.
When it's septic only, that's pretty easy, but when it's an illegal dwelling.
Well, that's why, that was my point. I think that is squarely in your area. Other code violations fall more in the county, where it's our code that's being violated or your code, whichever county we're talking about. So I think you have to look at the issue and then decide whose jurisdiction is most affected, and then that would be the lead agency.
And I think that's what we probably need to work to get to, is identify who the lead is, because sometimes that's where we kind of stall out, is we have violations.
Yeah, well, as Mike pointed out, I mean, in some cases, DEQ may be our best, maybe the lead agency. If it's going into a water source,
You have
they've got
raw sewage in
pretty strong
areas. If you're breaking state law because it's breaking what it's already in place for DEQ.
Right.
I mean, that isn't automatic. It should be automatically going to DEQ to get them to get involved to help get that taken care of. Because they're the ones that actually, they say they don't have the hammer, but they have the law behind it. We don't have it. It's like they do. So,
Well, that's kind of, if I remember correctly, and that's what ultimately happened with that place in Caldwell where they had the small lot and they had the septic that was too close to the wells and they had to go and get permits from the neighbors, but ultimately DEQ took that, right?
I think so. I'm not sure exactly which one you're talking about.
It
but I
was
think so.
deferred, yeah, I think he's talking about Master Lane.
It really, well, the last lane, yeah. It really depends though, and I think what we've also found success with, and it also can be not just on our lands team, but on the foods team too, is having a prosecutor that's willing to take it up. So we've had instances in any county where we've had complaints. There are rules, or they've kind of fallen under our jurisdiction more than code enforcement. And as long as we can work with the prosecutor and they're willing to do it, then we've been able to have some authority to take care of the issues. But it really was back to the relationship, because there's sometimes the prosecutors aren't really willing or they don't have time, but they've been pretty willing to. They don't know our codes, so we have to give them all the information. We even kind of do a little bit of the write-up for them, or the officers are going out and the ones taking up the information and then presenting it to the prosecutor. But it kind of varies on how we can enforce some of those things, but they're all complaint driven primarily. So that's where it gets a little bit difficult. And then it's almost like we are the ones ferreting out this code, is this, DEQ, and it's been falling on us to kind of decide which way to go on that. But then it's just back to relationships, if we can do that. So if the counties, if we want more done, then we really have to get the relationships with the prosecutor and the code enforcement and have them with us to know which route to go. I think that's what we've also had some get stalled out.
With your prosecuting attorney, you better have him with you. Because he represents the county as far as the county goes. He represents the county. If he's not comfortable with it, then you better not do it. Boils down to.
So when you get one of these calls, do you contact the county?
After we issue the notice of violation, if it's not remedied, then we would notify the county. And unless they're already involved, some of the counties, especially can't name any names, but.
I work with Mitch. He calls me whenever he has, we have he gets a complaint, so.
Yeah, I think Mitch tries really hard to move the counties in when we know there's an issue. He does a really good job. Yeah, so.
I would love it if the RVs were the worst problem.
Yeah, right.
That's what I had, Mr. Chairman. The answer is you do have authority. You don't have to wait for a complaint. You can do it on your nickel. You can work with somebody else. You can try to work jointly, or not.
Yeah, I work with the department or of the district health. I always involve our prosecutor just so he knows that we're looking at things, and then give him any details that we're going through. So, and if we have to get DEQ involved, and I don't have never called health and welfare. So if I've ever done anything, it's been through DEQ. It's usually a water, but once the septic issue is found and proven, then it becomes more of a water issue after that, because then you're contaminating surface water by doing that. That's
That's for me.
Thank you very much.
Thank you. What an interesting assignment. Learn more about nuisances than I ever expected to.
Let's see what code books you must.
Yeah. 3 books full.
There'll be paperweights soon.
Yeah.
Same. I like 3 books. I'm only going.
How do you give your sites those to you? We do that every year. You update them.
Yeah, they send updates every year.
Yeah, service. And they send you a, it's called a, they update it, and when it gets to be substantial enough, they give you the volume, so.
I still like to use these because they have all the cases.
I use the same one, annotated, yep.
Yeah, as compared to just going online.
Then you can go pull up the case and
Yeah.
do it all the time.
I'll leave
The
it.
the young attorneys, they do everything.
Yeah, I know. You can't get them to stop.
The nice thing about
Thanks, Mike, later.
the other nice thing is you can go section to section without going back and clicking and having forward screens up on your desk. It's like the book.
Next on the agenda is resolutions and position statements. IAB.
I'm trying to work this year to determine what policies we want to prioritize. I don't have a handout for this for the next legislative session and any position statements we want to develop. So I've talked a little bit with our team, maybe last week, and so I thought I'd just share kind of what we're thinking and get your input. I'm sure we can fill in all the gaps that cover. So kind of at the top of our list, we're continuing to address food fees. And one of the questions I have around that I didn't answer right this second, but we come back to it, is considering maybe hiring a lobbyist or having all 7 districts, if it's a priority for the districts, to do that. I think having IEC support it last year was great, but I feel like we need more time, someone like more dedicated time to really focus on that. Just based on my last couple of times when we have been successful to get those fees. At the time, we were going to try and get them increased, not just get taken out of code, but it was a good several months of work and one case, well, maybe both. We worked on it for 2 years. We got a lot of work. So something to think about. And then we also talked a little bit about Kratom last year. There were, I think, 3 bills introduced with varying levels of addressing Kratom. Currently in Idaho, there's no restriction, so anybody can go in and get whatever they want at any age. So there were varying rules, or I should say rules, bills last year drafted to establish an age to purchase all the way to like a complete ban. So we talked a little bit about that internally. Is that something as a health district we want to lead on and provide some law language to maybe a bill sponsor? And then those are kind of the 2 that we talked about with resolutions specifically. Then we talked about maybe developing some position statements on medical marijuana. It sounds like that might be on the ballot. I guess we need to do that sooner than just like a session of it, said that out loud. Although if it passes, then I guess that's when we would also.
Did it actually meet the threshold to be on the ballot?
I heard that.
Yes, it hasn't yet.
It's a slippery.
Yeah, the phrase that it hadn't been, and yeah, so
Okay.
it was kind of a mess.
When we're watching. So last year, there's quite a bit of talk in the state house about abatement of rodents. I don't know if that's something you want to take a position on.
Be back.
Yeah.
I'm sure it
It's
will.
coming back.
So,
I mean, what, like, I'm not sure what position it
Right.
would take.
Isn't that already a thing?
Yeah.
well, kind of like what Mike was, I mean, there's abatement laws that already exist.
Yeah.
I think it's maybe more on a money issue, like who pays for the abatement? Or is, maybe we don't want to touch that one.
Yeah.
I mean, it obviously would
It's a public
fall,
health
if
issue.
you have a rat infested lot full of junk, it falls into that nuisance category already. I don't know.
Yeah.
Need another law to say, clean up your rats.
Yeah.
I feel like between public health and counties, there are laws. I just don't know that there's, money to,
So we say the biggest issue is the money.
yeah. We've talked quite a bit over the past few years around groundwater protection. And Commissioner Reed had asked if we have any data on pros and cons of individual versus community wells, or which we don't, but we can do some research on that. That was one that came up, and I think just with the growth that we're seeing and kind of beyond the city limits, that's probably not a bad one to think about. One that I wrote down that I've been told that pretty much has no hope or prayer, but still thought I'd bring it up, is parity reimbursement. So currently, I'm talking about EMS reimbursement. Currently, there is reimbursement for 988 mobile crisis response. If someone calls 988, mobile crisis response is dispatched, even if they don't transport to ED, they are able to get reimbursement.
Medicare, Medicaid.
And as you know, 911 EMS only gets reimbursed if you transport. So there's, in the state, there's now a precedence to be able to get reimbursement. That's something that could be explored and be great. But,
That reimbursement's not even covering the cost of
No.
the actual transport, so it's again, like, REM's 90% transport, dig the hole even deeper.
Much better than nothing.
Inventory your prisoners in the county jails.
No, I think you're talking about getting paid if you have a call but you don't transport, right? Which right now we don't get.
right, yeah, so you're kind of incentivized to transfer, which has its
Right
own
now,
kind of
yeah.
consequences. So,
And to your point, we lose money regardless, but
Yeah.
at least we can claim something. A fall and I need help get back in the chair.
Right. That was what he's talking about. The treat and release through Medicaid. That's the first time I've heard of that.
Well, and I think, I mean, outside of like the EMS pieces, if we developed something that's uses different types of workers, like community health workers, healthcare navigators, those, we are able to bill for some of those services. We need to do a little bit more work on figuring out what that is. Cost reimbursement might not cover its cost, but there's other.
It didn't sound like it for Jathan, except not only the phone system, but nothing is covered 100% anyway. So
it's a little bit of a different issue, but the parity piece, I think, is something that we could explore. But I don't know if it has if it's worth, you know, really pursuing right now. It doesn't sound like there's much appetite to expand reimbursement for anything. But our internal team talked about there's quite a few schools that are now banning cell phones, which is something we've talked about as a board over the past few years. I think that's something we could take a position on and support schools
To advance the mental health of our children.
Mm-hmm.
I agree.
Yeah, and learning. Yeah.
Suicide.
Have you talked to Julie Palmer about it?
No, these are just ideas right now. We haven't
okay.
formalized anything.
I've talked to him quite a bit, like he's leading the charge of Valley, you know, as the assistant super.
Good.
So
I think it ought to be.
if we go down that road, he'd be a good one to talk to about it.
Yeah. And then I wrote down, I should probably done talking about this today, but RV black water disposal. And I don't know if there's a position, because I know laws already exist, so maybe there's nothing more we need to do. But it is a challenge. And even if it's, you know, one thing we talked about internally, some of you probably noticed this too, that the number of publicly accessible dump stations has been depleting over the years, and there's not really very many in our district. So yeah, I know a lot of people who recreate and some who live in them.
Maybe that's something that needs to be looked at.
Yeah. So thinking about maybe other solutions outside of like what our laws could
I think you talked to Mitch about that. He's pretty well informed, and we're going to have a big problem real quick on how much capacity to take that kind of stuff, which, you know, won't just be the ones we're talking about here with Blackwater, but it will be all the recreation folks too. So it's a bigger issue.
And the other kind of related issue is the pumper trucks not having a place to dispose of, because I think that's in the county or in the district actually.
Having a very big issue.
Yeah,
septic trucks.
Yeah.
And maybe
the septic trucks take them to Clay Peak.
Yeah.
But then there's only one company that will transport it over to Caldwell to get rid of it. And they hiked up their price significantly this year. And so some of the local small septic cleaners came unglued. They have to raise their prices to come with that. So anytime you raise prices on disposal, you'll end up getting broke.
So concern for us too is Caldwell saying we're not taking any more outside, especially as they're growing, right? And their city and not necessarily expanding the capacity of their. That's our list, and Commissioner Review.
So, you know, some of the behavioral health gets into other discussions and things that concern me that aren't necessarily health districts. One is the amount of pharmaceuticals that kids are told about. I think is leading to a lot of other problems. I don't know if that's or and psychopharmaceuticals in general. I think people are really overdosed on that stuff.
System is broken.
Yeah, well, I mean, we recognize that there's a big mental health problem, and I think a lot of times the treatment for that is here as a prescription.
It's all about us.
Yeah, they make it worse.
Selling drugs.
I don't think the advertising doesn't help either.
And then the bill for that
Pharmaceuticals, rich, it fixes everything.
All right.
So I see that as a growing problem, but I don't know.
We've had obviously the Marsing Hub has been a great success story for some of that too, because it's not based on medication use, obviously, it's based on connection, activity, like all the other things that we know are helpful in prevention of mental health, suicide prevention, depression management, all the all the things. And so that's where hopefully our community health team can help, but it really has to be part of the community too. Like, what do they want and how do they want to engage the best? And that, that's a very difficult process sometimes to get the rest of the players in there. But it definitely can be done. I think we're seeing the show, they're going to be very successful.
Maybe because like I was sharing with you, we're not like a researching. Right. So that's not our strong suit. But I think it is very appropriate for us to be able to say but we know that like healthy activities and having like an adult that you can look up to as a youth, we know those improve health outcomes. So maybe rather than trying to unravel like the pharmaceutical side of things, it's focusing on like the positive behaviors and things like that. So we could have a position statement around that potentially if there was funding or policy that opportunities that supported those types of prevention activities. I don't know about the other side. It's a little bit more complex. Right. Yeah, I know. Trying to unravel the healthcare system.
And you had mentioned some kind of intervention when people get out of jail. Is that another one that?
Yeah, that's
position wise.
Yeah, I don't know that from a policy perspective. I mean, I feel like we're kind of in an exploratory phase right now. We're doing that pre-prosecution diversion program with Camden County, which is starting to gain some momentum with the prosecutor's office, I feel like, and looking at that for, acknowledgement or like, no, and I went to the most recent graduation, which was really neat to see, like, but one of the other things that we've talked about, pursuing potentially with the rural health transformation funding, and it's kind of tied to the EMS side of things too, because there's a little bit of overlap there, but is when people are leaving jail and trying to connect with them at that point. There's a program out of Colorado called like a transition assistance program that's for specifically people leaving jail who have that mental health or substance use kind of driver of what's happening in their life and why they're ending up back in jail. So the recidivism thing. So that is something that we've looked at piloting as part of our request for funding through the Rural Health Transformation Grant. So I think more time would be needed to give that an opportunity to pilot. And then if that were showing benefit in both health outcomes and jail recidivism, then that would be maybe something to have a position statement.
I guess way more as a priority, something. This year should be doing. I mean, it's just like a revolving door to get out, get back in, get out, and just fully expect to go back in.
It's cycle the break. Yeah, people takes multiple attempts. Are there any other? So those are the kind of the ones we were thinking of before we develop them and bring them forward for the board to approve here soon. Any other ideas? Great. Well, we will take input if you think of something later. Okay. Director's report. So there's I say a few, but I think there's just a couple of grants, contracts, and sub-grants in the back of your binder. If you want to look at those, if you have any questions, let me know. The Rural Health Transformation Grant update. So I wanted to just make you aware. I mean, I've talked about this the last couple months, at least, probably thinking about the health district pursuing a couple funding opportunities. We're looking at that. The state did finally release on their website what kind of opportunities they're going to fund. They've already released a couple funding opportunities. Those are specific to maternal and child health and obstetrics readiness. There's one around facility renovation some of these are for looking for larger vendors to like oversee projects. There's a project management support, RFP out, and a data analytics and outcomes evaluation. RFP out. Some of the others that I thought EMS and even the jails that we have medical, which I think you'll have to have some kind of medical. This funding could help with purchases for medical equipment, ambulances, renovations, like EMS services, but also potentially jail medical. I have a meeting next week, Commissioner Brooks with Sheriff's Office on women's jail. It's going to go to and talk about. They wanted to learn more about what these opportunities are. So thinking about they need charting software, retention or training funding for medical staff, and it doesn't have to be medical staff that you hire. If you use a company or third party, you can it's like pursue funding for that. Cybersecurity, infection control enhancements, so trying to isolate ill inmates from healthy ones. That could be a use for these. Pharmacy management, global crisis. So there's a lot there, and I would anticipate that the EMS and maybe jail staff might be interested in looking at those. So I just wanted to let you all know, and if you we're happy to be a resource, I guess, if we can help direct them to where the funding opportunities are. And we have our grant writer. She's also going to be, I know, writing for us. I did have a conversation with Clearwater Financial last week, who I know some of you have worked with, to see what kind of support they might be able to provide. And they do have a grant writer also. So if we end up being little grant writer short for these, there might be some, they might be able to provide some help too. So just wanted to throw those out there, make sure that's.
Is that going to be released to like to the EMS?
You have to go look for it. That's why I was saying if you want me to send you the links, and I'll be honest, even with the links, not that intuitive to find. So, but I'm happy to send it to you. And I didn't share this, but like the most flexible funding is also the largest amount for this first year, and it's 93 million for the state. Or there almost 94.
Requirements are rural.
It is. I mean, this is all part of our big beautiful bill, and it is very geared towards rural health. So anything,
but maybe all of Idaho would be considered rural.
Yeah, except for maybe Ada County, but
I know our hospitals put in a pretty big ask for the first round.
What did they've already put that in?
They can't. Yeah,
they're working on it. Yeah.
Probably the concept. So these are still, unless it's the maternal, but you guys don't do OB anymore, right? Yeah. So some of these aren't available yet. So the process is the ones that I just mentioned at the beginning, those are out and posted for RFP, but they're mostly looking for like one vendor to do something right now, with the exception of, I think, the maternal and child health. But the others, once the state staff write the RFP, it has to go through the Legislative Oversight Committee. So some of these are at Legislative Oversight Committee, and some of them, like the 94 million, is still under development with the staff at Health and Welfare. So there's nothing even to look at yet, other than this little brief blurb of what they said they would do.
Will you send those on to us when they are available? Are you keeping an eye on that?
I am. I'm watching it. Yeah. Is that, would you guys like me to do that? So I can send you the links when they go live. Okay. Okay. That's that update. And then I wanted to just give you a couple updates on some infectious diseases that we're monitoring. Not necessarily locally, but I think everybody's heard there's an Ebola outbreak happening in Africa. And that outbreak is continuing to grow in the in the Democratic Republic of Congo. I did learn yesterday that the cases that are now occurring in Uganda are so far all connected to people who were exposed in Democratic Republic of Congo. So there's not like community spread right now in Uganda. But like what our role is right now is just in monitoring that situation. And then if there are individuals who are citizens of the US that are returning from those areas where there's outbreaks, there are several layers of screening that occur with them. And then when they, if they're kind of determined not high risk, they will be able to come back home, and then they are being asked to self-monitor for symptoms for 21 days after their departure. And we're notified of them and where they are. So what I've been doing, if anybody shows up that's on our radar and is doing the self-monitoring, just notifying our board member that's in that county that there's somebody under monitoring.
And there are any travel restrictions for people coming back?
There are travel restrictions for people coming back. Yeah. But if they fall into this category and pass through all the screening, then they're able to return. Otherwise, they're diverted to other places. So that's Ebola. You probably heard about New World screwworm as well. Making a comeback. It is something that used to present in the US in the past, and you've probably heard primarily about the agricultural concerns, which are very real and concerning. New World screwworm can also infect people, though, so that we are also kind of monitoring it from the person's perspective. There haven't been any human cases at this point identified in the United States, but we do now have at least 2 states where the fly and infected animals have been seen. So
7 in Texas, 1 in New Mexico.
Maryland, and a dog in Maryland.
What?
that's new to me.
I thought it was just cattle down in.
No, and a dog in New Mexico too. Yep. Yep.
Maryland.
So I'm a little concerned, I won't lie, because with the amount of movement of animals during summer fair in Rodeo, and just regular cattle sales and all the other things that happen, dog sales. Yeah, I have a concern that this is going to get bigger before it gets smaller. But we are watching it. We have started developing some communications in advance. So if it does show up here, we're fairly prepared to send out messaging around public health exposure and to providers and what to look for. So they can spot that too if they see any human cases of New World screwworm. And then the other that I want to make you aware of, if you're not already aware, is highly pathogenic avian influenza, which is currently circulating in dairies in Idaho. And
same one, or is this a new one?
I think it's the same H5N1 that was circulating last year, but it kind of died down and almost died out. It's made a resurgence, yeah.
And because it was in Jerry's before too.
It was, yeah. Yeah, so we're watching that pretty closely. Currently, there's 20 dairies in our district that are under quarantine. And so what we've been doing is communicating to health providers on what to look for with people presenting with flu-like symptoms, to make sure they're asking if people had exposure to cattle that were sick. But we're also expanding that and to pigs and birds, because flu moves between those groups, and that's when it gets more at risk of having sustained spread, is when you have that mixing between different animals. And again, we have fair coming up, and we're really a little nervous about that. I'm sure it'll be fine. But
how many did you say in our district?
20 of the 80 that are
dairies. And is that human?
These are
illness or cattle?
Cattle, but we're concerned on the human side, although that's cattle too. So we're wanting to try and keep tabs on any animal to human transmission, and hopefully that just stays as one animal to one human. What we don't want to see is animal to human movement, like that kind of transmission happening. Especially with H5N1, that's the influenza strain that caused the 1918 pandemic flu. Wow. So it's a pretty gnarly strain that we don't want to see sustain transmission to people.
Is it the exact same strain?
It's the H, well, it's the same as the H5N1, I'm sure it has.
Because the people that I mean, it did jump to people last year.
It does, but then it didn't jump from person to person.
But it wasn't that serious either.
No. I think that's source. I might have that in. Last year, there were 71 sporadic infections and 2 deaths out of 71 cases. I don't know what that. So.
Vectors that are underlying.
Yeah, there might have been, I'm not sure. I mean, and I don't know if these, most of these are probably, these were poultry exposure, so, or dairy. Yeah. So those are the ones that we're just kind of monitoring and trying to have, make sure providers are informed and citizens too. You might see some of we're preparing some information to go out to fair boards to post during the fairs to encourage good hygiene. You're handling your. And we've also provided some information to dairies and to coroners also. And then the last item for my update is just legal counsel update. So Mike Day here, as you know, he's retiring. Russ Duke and Mike, and I did some interviews last week of top 3 people that we identified, and we are still working on the decision, but all 3 interviewed really well and feel pretty confident. Great one of those things.
If the health districts decide to hire a lobbyist for the fees, what's that going to look like?
And I think it's a good question because it's been Mike the last 2 attempts where we had success. And I asked him if he would be willing to do it next year, just in case, because we'll have somebody new coming in. But and he said no. So
Can you recommend anybody? Does he know anybody?
Well, we're with the legal counsels that we're talking to. We're seeing if that's something that they're willing to take on as well. It takes a little bit. It can be a pretty big time commitment. And the other thing is that I'd say if all 7 districts decide to do it, it doesn't have to be like our legal counsel or the one that we share with District 4, ideally. But it does help that it's somebody who lives here locally because you have to be down there so much. So there's a good chance it'll end up probably being somebody here, but we have time to figure that out.
Great to get somebody that has some history with the food restaurant industry.
Yeah, it would be, but
maybe not very likely, but
yeah. Or good relationships with the legislature. I feel like that's just.
Anything else?
I don't have anything.
Anyone else have anything? Okay, and it is 11:41. We are adjourned. Thank you very much.